Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we are going to talk about something called patellofemoral pain syndrome, and the name really helps us to understand what is actually going on here. So if we briefly orient ourselves, remember we have the femur, which is the longest bone in the body. We have the tibia, which is our shin bone. On the lateral aspect, we have the fibula, and then this structure in red is the patella, sometimes it's also called the kneecap. So patellofemoral pain syndrome is a syndrome that occurs in kind of this general area. Part of this area is also called the patellofemoral joint, and that's where the name actually comes from. And so patellofemoral syndrome is a pain that's associated around this area. Now, when we think about knee pain presenting in a patient, we need to think about some things on our differential. So some of the common classic ones we need to keep in mind are osteoarthritis, rheumatoid arthritis, septic arthritis, but there's some other ones I want you to know as well. These can include things like Osgood-Schlatter disease, potentially a stress fracture, or other things like a tendinopathy. This is not an exhaustive list, but we'll talk about how some of these can have a similar presentation during later portions of this video. Now, when we think about the etiology here, it's important to note this is a common cause of anterior knee pain. So if you draw your attention back to our differential diagnosis, what are some other things that can cause anterior knee pain? Well, a very classic one is going to be this Osgood-Schlatter disease, very common in childhood, right during our growth spurt, particularly patients that are involved in a lot of jumping sports such as volleyball or basketball, can actually develop an avulsion of the tibial tuberosity, which is kind of at the front of the knee over here. Right, we have the quad tendon attaches to the patella, then the patella attaches to the tibial tuberosity, and this can create anterior knee pain as well in an overuse injury. Now, with this condition, it's also important to know that there's increased risk with knee malalignment, muscular imbalance, and repetitive activities. So again, the repetitive activities gets back to a similar thing with Osgood-Schlatter disease, and the knee malalignment or muscular imbalance makes sense because really you can think about this kind of as like a tracking issue, right? The knee can go from a flex position like this, and if it goes outwards, that becomes more of an extended position that can look something like this. And all during that time, right, we have the patella or the kneecap that's going back and forth in this groove, right? It's going back and forth as the knee extends and flex. However, what if there's an imbalance muscularly? What if it's rubbing more on this side? It's going back and forth on this side more than this side, and it's getting more wearing out over here. This can ultimately predispose patients to things like patellofemoral syndrome or even osteoarthritis later on. Now, when we think about the pathophysiology here, it is directly related to some of those risks that we just talked about. Poor knee alignment or imbalance leads to biomechanical overload. Remember, we talked about how one side can get overloaded more than the other side, and this can ultimately lead to increased patellofemoral joint trauma. And again, this is the patellofemoral joint itself. It's kind of that joint space between the patella, the kneecap, and the femur. And ultimately what happens is the increased patellofemoral joint trauma can lead to knee pain. If we have biomechanical overload and one side is worn out or one side becomes more traumatized than the other, this can of course present as knee pain. Now, when we think about the presentation here, this is classically going to present with a dull pain over the front of the knee. Again, we talked about the important compare and contrast with this versus Osgood-Schlatter disease. One of the classic things is going to be the X-ray imaging. In Osgood-Schlatter disease, you can actually see a avulsion of the tibial tuberosity that can come off the bone versus in the radiograph of somebody with patellofemoral syndrome, it's typically unremarkable. Now, these patients can also present with tenderness over the medial and lateral patella, as well as crepitus with range of motion testing. So what is crepitus? Crepitus is like a crackling, a popping sensation in the leg as you're moving it through motion, right? So if you have a leg and you're moving it from flexion to extension and back and forth, right, you can hear some crackling sensation. That is crepitus in the joint itself. Very common with a lot of other conditions, particularly osteoarthritis is a classic one. Now, patients can also present with increased pain with weight-bearing activities. And a very classic way they'll ask about this is a patient that's having pain with climbing stairs. Additionally, patients can also have pain with knee flexion and extended periods of sitting. Patients might also report that their knee buckles due to the pain and that it gives out and potentially even that they fall. So a key here is how do you differentiate then this classic presentation with some of our differential diagnosis? When we talk about OA, we often think about the age, right? Typically OA is an older patient, although not always. Rheumatoid arthritis is going to have more systemic symptoms, right? It's an autoimmune condition that typically is going to present in a variety of different joints, not necessarily just one knee. Septic arthritis is going to be accompanied by a fever and a leukocytosis. Patients are going to be sick. They'll have a big, swollen, inflamed joint. Patients who have Osgood-Schlatter disease is probably one of the more similar ones to patellofemoral pain syndrome. Key ways to tell us apart are going to be the X-ray findings, the physical exam, whereas Osgood-Schlatter is going to have a bulge at the tibial tubercle in the knee. Somebody with patellofemoral pain syndrome might have a very normal appearing knee and a very normal appearing imaging exam. Another key one to think about with a differential diagnosis is a meniscus tear. And one of the key ways to determine if a patient has a meniscus tear or patellofemoral pain syndrome is to do the physical exam. The meniscal tear classically is going to present with the positive McMurray sign. And that's where you can kind of internally or externally rotate the foot while you're moving the knee. You're pushing it through extension and flexion, and this can create pain sensation for the patients if there's a meniscal tear that's getting caught during that motion. Typically with patellofemoral pain syndrome, this should not necessarily cause excruciating pain. However, we did talk about you can potentially hear crepitus with this motion. Now, when we think about the diagnostics here, this is often a clinical diagnosis. We don't typically need imaging for this to occur, right? Based on these findings, based on the physical exam and compare and contrasting with some of the other conditions that we've talked about previously, you can diagnose this patient. Additionally, the history is going to be very important. Is this patient involved in repetitive type activities? Might they potentially have a muscular imbalance? They don't participate in strength training. All of these are going to play a role in actually determining that the patient has this condition. However, although imaging is not routinely indicated, it may be reasonable to get an x-ray to rule out other causes of knee pain, right? If a patient comes in with acute onset knee pain and they had a fall, you need to rule out a fracture. Patients might also be developing early stages of arthritis. So it's important that even though this is often a clinical diagnosis, we still consider the imaging findings that I'm highlighting in blue. So just briefly to go over this image, this is the patella right here, and this is kind of that patellofemoral joint space. You can see there's not significant arthritis. There's a good amount of space in between the bone. There's no bone spurs coming off. There's not a lot going on. It's a fairly normal radiographic finding. However, it's potentially important to get these because what if it did show us something like a fracture line through the patella? That would be important, right? And the treatment for that would be much, much different than the treatment for patellofemoral pain syndrome. Now, when we think about the management here, this is typically going to be managed with conservative measures. This includes things like RICE, which is a very common memory aid that stands for rest, ice, compression, and elevation. Patients might also benefit from NSAIDs or anti-inflammatories, physical therapy, and if the patient has a muscular imbalance, we talked about being a risk factor, one of the classic reasons for this is that there's an imbalance with quadricep muscles. So focusing on quadricep strengthening, particularly the VMO, to help improve the muscular imbalance and potentially the knee malalignment. Additionally, some other options include things like orthotics and weight loss, right? Anytime we take off weight from the body, we're taking off the pressure that's put on the joint itself. So this can help relieve some of the symptoms. Now, patients may rarely need surgical intervention. However, this is the last resort, and I would say it's unlikely to be the answer on test day. So really make sure that the patient can't improve with conservative measures before you pick this option. So just a quick summary to wrap up this video. We're talking about patellofemoral pain syndrome. Remember, there's a lot of different things that can present with knee pain, and we need to think about one or two things to differentiate them so we can get our questions right on test day. When we think about the etiology here for this condition, this is commonly going to present with anterior knee pain. There's increased risk with malalignment of the knee, muscular imbalance, and repetitive activities. The pathophysiology ties into these risk factors, right? If you have these things, you're going to increase biomechanical wear on the joint, which can increase trauma and ultimately lead to the knee pain. Presentation is classically going to be dull anterior knee pain that can worsen with knee flexion and weight-bearing activities. Diagnostics here, this is often a clinical diagnosis based on the patient's history, based on the presentation. We can often make this diagnosis in a patient. However, imaging could be used to rule out things like fractures, dislocations, arthritis, but if you do get an imaging finding, it's typically going to be a fairly normal x-ray image. Now, when we think about the management here, we're going to pretty much always try to do conservative management with rest, ice, compression, anti-inflammatories, elevations, physical therapy, quadricep strengthening, but in very severe, rare cases, surgical intervention may be needed. So how might they ask about this pathology in a question stem? They could give you something along the lines of, a 22-year-old woman presents to the primary care office with new onset knee pain. Patient reports she recently began training for a marathon with her best friend. She reports her mother has rheumatoid arthritis and her father has osteoarthritis. On physical exam, the patient has pain in the anterior knee, but no significant joint line tenderness. There is mild crepitus when passively flexing the knee. The question could then ask which of the following is the most likely reason for the patient's knee pain. It could give you all kinds of knee pathology. We talked about all kinds of things up here, but again, this is not an exhaustive list. So they give us a lot of tricks here. They talk about the mom who has rheumatoid arthritis, but without other symptoms in this patient, it's unlikely they have that. Dad has osteoarthritis. Again, this is a younger patient, 22. It would be unlikely for them to develop osteoarthritis at this age, although not impossible. The patient has anterior knee pain, but no joint line tenderness. A key point here, when I said the patient has tenderness, it's typically medial and lateral patellar tenderness if they have patellofemoral syndrome. So the fact that this patient in our question stem doesn't have joint line tenderness actually decreases the likelihood they have a meniscal injury and increases the likelihood we're dealing with patellofemoral pain syndrome. Additionally, the patient just recently started training for a marathon with her best friend. Oftentimes, patients quickly increase their activity level, particularly repetitive activities such as running, which the patient is doing, which can lead to this condition of patellofemoral pain syndrome. So although there's a few different directions we can go based on the question stem, the most likely thing that this patient has is going to be patellofemoral pain syndrome based on the location, based on the history, and based on the presentation given in the question.